injury and burn care in rural Kenya.
Thank you so much for that presentation. I think the work and what you outlined is very pertinent to my project that I'm going to discuss today. So my disclosures are the work that I'm going to present here was done while I was a resident at Brown, and that is where I received the funding. For this talk, I wanted to kind of take things globally and bring it down to kind of more locally in the story of how I ended up in global health and doing burn research, and then also talking about where I was doing the research, how that informed the projects that we did, and some of the results that we were able to present as a result of the research, and then a reflection on the experience. So, like maybe some people who get into global health research started from very self-serving motivations. When I was a medical student, I really wanted to go on a great adventure, and so I looked for an opportunity to go and shadow physicians in Cusco, Peru that worked at the community health program. And my goal was to travel, but what I found was kind of this field of global health that really inspired me and gave me a wider view of the world and what was possible. Because of that, I delved deeper into the field of global health. I did a master's program where my thesis was focused on global health and global health ethics. And as a fourth-year medical student, I worked with a community health program in Nicaragua that went out to rural areas to really empower local health by training community health workers and supplying training and resources. And my role there was to do quality improvement research, so taking the records from the community health workers and collating them and making them into something that can be then reflected back into the system and be a part of the cycle of improvement where you're taking data, analyzing it, and then giving it back to that program so that they can continue to improve their efforts. And that really introduced me to how research can really be used as a tool within global health to improve local communities. I'm going to go ahead and just skip over this slide because Dr. Campos did an excellent job outlining the issue of burns globally and the need for more research and improvements in care, especially in resource-limited settings. So my residency program had a relationship with a hospital in southwest Kenya that was in a rural area that provided local care to about a population of about 800 people, the majority of which worked in agriculture and lived below the international poverty line. They also served as a referral care center for a huge portion of southwest Kenya because the mission hospital, due to a lot of the resources coming in from outside the country as well as support from the local area, was able to supply a lot of surgical subspecialties. So there was orthopedic surgery, trauma surgery, neurosurgery, as well as obstetrics and pediatric surgery there. And so people kind of knew that there were these availability, ICU care as well at the hospital that really created this large informal referral network. So my goal was to look at how burn injury was treated at Tenwick and to create usable data that also, again, could be reflected into that program for future improvements. So the first thing we looked at was a retrospective chart review, and we gathered charts on burn injury patients that came to the hospital from 2014 to 2017. These dates were chosen because they actually implemented an electronic medical record system that allowed coding of the patients, and so we were actually able to pull records based off of coding and not just through review, and that really allowed us to streamline our efforts. For this first project, we defined mortality as in-hospital death from any cause, looking at the burn patients, and then we just wanted to kind of compare survivors versus non-survivors and what that could tell us about the care there. The other thing that we calculated was an LD50, and so you might kind of remember this concept from pharmacology where the lethal dose where 50% of people would die as a result of that medicine. For burn injury, we calculate that based off of the total body surface area, so meaning the amount of your body that is covered with burn injury as the dose of the burn. And so calculating LD50 kind of allows a comparison over different facilities and different settings to say how big of a burn can survive in this hospital setting. And so we collected data on 171 patients with 2 excluded due to missing data. The overall mortality for this patient population was about 15%, and the LD50 for the burn size was 42% total body surface area. And then the modified Bow score is just another way to calculate likelihood of mortality, but I think not pertinent to this discussion. So looking at the survivors versus the non-survivors, we saw a lot of the trends that we see in burns overall, which was that there was a higher total body surface area, more likely to have full thickness, more likely to have inhalation injury. But you can see in the age group here, which we included all of the patients, and similar to, again, global data that, 2/3 of our population was the pediatric population of burn injury, which is very typical all over the world, but especially pronounced in resource-limited areas. And so looking at our multivariable regression, we found that the odds of mortality at this hospital increased about 6% for every 1% increase in total body surface area. And that the odds of mortality increased almost 14 times for patients with inhalation injury. And that's, again, also something that we see in the United States, even, and all over the world, that inhalation injury really contributes to mortality. One of the interesting things we were able to do as doing this chart review for this individual hospital was give some feedback to the hospital about where do you sit in relation to other areas of the world. And so the Global Burn Registry, which is a really important effort in trying to gather data globally, did a report where they reported the LD50s, total body surface area burns, comparing, so the ABA NBR, that's the National Burn Registry, and so the American Burn Association verifies burn centers, and so the ones that are verified would be probably the areas of the quaternary referral centers that have the highest access to technologies and expertise when it comes to burns. And so what you can see is that the LD50 increases in those areas with more resources and decreases in areas with low resources, but that you also see a trend over age, which is as you get down to the older areas, the total body surface area severity of burn is really affected by age as well. And for Tenwick hospitals, this orange line here would be our LD50. And that would be, interestingly higher than other low resources areas that respond to the burn register, or the Global Burn Registry, but definitely there's a gap related to resources in the ability to support burn injury. The next thing I wanted to look at was the referral patterns from having worked at the hospital. So I was there for about 6 months collecting data for these various projects, and I also worked as a resident. They had a residency program there. And so I was able to kind of insert myself as a visiting resident. I noticed that a lot of people would come to Tenwick knowing that they had access to things like excision and grafting. They had the ability to bank blood and other things that weren't available in the surrounding areas. And so what were the referral patterns? So it was the same chart review, and for this we classified a referral as anybody who had been seen at another healthcare facility prior to coming to Tenwick. The limitation there being a lot of people would self-refer, meaning they would leave another place or they would be seen by a doctor at another place and then come here voluntarily, versus a physician or a medical provider at another hospital saying, you should go to Tenwick for your care. So we were able to delineate between those two classifications. But what we found was that over about 31.8% of the patients were referred or were seen at another healthcare facility prior to coming to Tenwick for their burn injury, and that in both parties that self-pay was the most common primary care group, primary payer group, and so there's no difference there. We did note that patients who were referred tend to have a higher total body surface area, were more likely to have full thickness, so those are kind of indications of burn severity, and that it did track that the further away you were from the hospital, the more likely you were to have been seen at another healthcare facility before coming to Tenwick, and that those that were referred tended to present much further out from their burn injury. So similarly, we wanted to see if we could isolate any of these variables to look for correlations, and we found that, again, burn severity in the sense of total body surface area, where you were more likely to be referred and have full thickness injury, and that your time of travel to hospital the further out you were, the more likely you were to stop and be seen at another healthcare facility. And then looking at outcomes for these patient populations, we did see an increased correlation with complications, and that was a composite complication of anything happening during their hospital stay. And that for those patients that required a procedure, there was a higher number of procedures needed. And so that really reflects, again, correlated with full thickness injuries more likely needing an operation than partial thickness injuries, which often even heal on their own. And so, you know, is this a signal that tells us it is the surgical subspecialty that's likely bringing folks in from far away to get their burn care?
1 minute, Dr. Hunter, thank you.
And so, one of the things that this showed is that it had not been documented before, that there's no official referral basis in Kenya, but that there is an informal referral system that's happening that you can see from this data. And that it reflects the differences in capacity, like even within a region, of who can do what and how that affects the movement of patients, although sometimes very inefficiently. So this is kind of a starting point. I also included
We conducted a phenomenological study.
but I'm gonna skip through to kind of go over to the reflections with my last minute. So I learned a lot during this period, and I think one of the things, again, from my past is that using research to help in a local community to really focus the efforts and the projects that we did was in partnership with the folks at the hospital of what would be most useful for them. And then when we were able to take it and publish it on a national and global scale, to take what other people were going to learn from it, but the primary goal was really to reflect back into the hospital partnership, and then having funding. So that was a whole journey of a lot of no's, but that being creative and finding the people out there who are really excited and want to support these future efforts. So these are all the folks that were my mentors and collaborators during the project. Thank you so much for the opportunity.
So our next presenter is Dr. Olajumoke Megafu from University of Massachusetts in Worcester. He's going to be talking to us about global health footprints, a U.S. resident perspective.
Hello, everyone. Hello. My name is Dr. Olajumoke Megafu. I am a general surgery resident at the University of Massachusetts, and welcome to our talk today on global health footprints, a U.S. resident perspective. I have no disclosures to do. So what is global health? We heard earlier on from our presenters one of the definitions given. Of course, it all depends on the perspective, of course, on who is giving the answer. But according to the Consortium of Universities for Global Health, it is a field of study, research, and practice that places a pride in achieving equity for all people all over the world. It involves health issues that transcend national boundaries, such as pandemics, infectious diseases, essential surgical needs. But also, sometimes we forget that global is also local, which means that it recognizes that health challenges in one region may have implications for communities worldwide. But for the purpose of this talk, I'll be focusing on global health from the perspective of beyond borders. So it's a growing hot topic, global health in general, especially among medical trainees in the US. And there are an increasing number of medical students who are immersing themselves in global health initiatives, but naturally, this has transcended into medical students who are now applying as residents, looking for opportunities with increased enthusiasm for engaging in global health initiatives and endeavors. But with the high demand for this medical students having more and more immersive experiences, do residency applicants actually have the resources or have the ability to evaluate opportunities at programs that are offering these opportunities for applicants at the time? In 2017, Dr. Howe and colleagues at Cornell performed a systematic review of US-based programs to see what percentage of programs in each field offered global health opportunities. They performed reviews on both published survey data and also reviewed web-based data. And here we can see, according to the survey-based data, that 83% of preventative medicine programs, 74% of emergency medicine programs, and 71% of general surgery programs provided some form of global health opportunity, with orthopedics and OBGYN programs with the least opportunities. However, when they evaluated what was published online for residency programs, they had noted that emergency medicine and pediatrics had the most visible opportunities. So while we can see that there are obvious discrepancies between the survey-based data and online data for programs, which tells us that, one, it proves that websites aren't necessarily up to date for programs with information for applying residents, but also that there is a clear disparity in access to these opportunities among and within specialties. As a surgical resident myself, I was curious about the data surrounding global surgery programs. A 2022 study by the Global Surgery Student Alliance sent surveys to 258 program PDs with only 45 responses. Now, of those 45 responses, about 93% of the respondents agreed that global surgery was important. However, less than 2/3 actually provided any of these formal experiences to their residents. And if you look at the table on the left, we see that the faculty participation in global health does not necessarily translate into residents' ability to participate. So what exactly are these barriers that are inhibiting residents from also being able to participate in global surgery opportunities? If you look at the table to the right, the top 3 barriers were funding, allocated time, and lack of faculty engagement. So let's parse these out individually. Looking at global health barriers, to understand the importance of financial backing from programs to support residents participating in global health initiatives, one must first understand the costs that are involved. So travel expenses, the flights, the visas, the vaccinations, the accommodations, all of these of course require financial support. And then there are the costs for obtaining necessary paperwork such as medical licenses, permits, that also cost. And then there's the cost of living once you're on ground, the living expenses, the meals, the traveling while on ground. And then depending on the program, there may be administrative fees or program-related costs charged by hosting institutions or organizations. Another barrier to global health is finding the right time, the allocated time. Now, we already discussed that not every single global surgery residency program actually offers, not every residency program offers global surgery opportunities. So it becomes on the onus of the actual resident to search for opportunities outside of their program to be able to engage in these global health initiatives. Then there are time constraints related to scheduling rotations for those programs that do offer, whether or not those constraints are related to scheduling rotations within the residency program, which may have limited flexibility, use of curriculum requirements, patient care responsibilities, and academic obligations. Ideally, it would be a 4-week at least rotation that is embedded within the residency training of the individual, and preferably accredited so that whatever they do counts towards their graduation. Or there's the other alternative, which is dedicated academic development time or research time. And then there's time that's required for obtaining the necessary documents like visas, permits, medical licensures, and practicing in the host country, which can vary in complexity and duration depending on the destination. And then there are also the faculty engagement that has been listed as one of the barriers to global surgery engagements. Dedicated faculty provide essential mentorship and guidance for residents engaging in global health initiatives. And it is imperative that having these faculty engagements provides experienced mentors, aids residents in navigating ethical, cultural, and logistical challenges. The faculty facilitate connections with local and global partners, enriching the residents' learning experiences, and fostering sustainable collaborations. But I'm going to transition a little bit into my personal experience, a little bit about how I got into global health and global surgery endeavors. So a little background about me: I was born in New York, but by ethnicity I am Nigerian, and growing up, my parents always had this wonderful idea that once we reached the age of middle school, they would send us to Nigeria to meet our family, learn a bit about our culture. And of course, I was there for 3 years, which meant that at some point I was bound to get malaria, which I did. And unfortunately, I had a cousin who passed away from kidney cancer, and that was my exposure to the medical system there. And I remember wondering, despite all the resources that we had, why was it so difficult to get access to the care that we needed? Fast forward my time to college, I had the opportunity to do a 1-week immersive experience in Honduras, which was great. It was eye-opening, but a lot of things didn't sit well with me. For example, we went in diagnosed people with diabetes, high blood pressure, distributed medications, and we went home. We didn't connect them with local resources. There was no long-term follow-up. And I figured this in no way could be sustainable. In medical school, I actually did have the opportunity to go to Tenwick Hospital, actually. But unfortunately, due to COVID, I was unable to make those travels happen. So when applying for residency, I knew that global surgery was something I definitely was something that was very much interested in. And I wanted to make sure that wherever I went, that they were well equipped to give me somewhere where I could have the skills and opportunities to explore this. I matched thankfully at the University of Massachusetts, where they already had previous global health experiences for faculty and residents, but also was developing a new partnership with the American College of Surgery Health Outreach Program in Equity in Global Surgery, previously labeled ACS Operation Giving Back. Now, SCS Hope had partnerships already with countries like Ethiopia, Lusaka, Zambia, and then also in Rwanda. So the partnership was there, especially for something that was long-term, something that was sustainable. And though we did not have dedicated clinical rotations to pursue global health opportunities, it did have the option for pursuing academic development time, which I did take, to pursue my MPH, but also explore my desires for global surgery and global surgery initiatives. So we had the faculty that was there, and thankfully it was from the top down, starting from our chair, Dr. Litwin, to our program director, who was very supportive, and multiple faculty members. Here we actually have Dr. Litwin, who is here at one of the initial site visits to the University Teaching Hospital in Lusaka, Zambia. And during one of our visits together, Dr. Kelly, serving as the clinical lead, laid some of the groundwork for development of laparoscopy, along with Dr. Fisher and Dr. Johnson over at Morehouse. And there's me to the far right in that photo. And then there is Dr. Perry, who is our pediatric surgeon, but also our research lead. So I clearly had invested faculty who not only were participants in this collaboration, but also leads in some of the working groups who both carried me under their wings with their full backing of our chair and our lead. Some of the work that we engaged in was research capacity building. This was identified as one of the needs during the needs assessment, and I helped to develop a year-long research curriculum with faculty from the US and faculty from UTH Hospital, where we met mostly monthly over Zoom, but when we were in person, met several times when we did get a chance to travel. Another portion that I was very involved in was our curriculum building, the laparoscopic simulation, and we had a blast doing this with the registrars, which are the equivalent of residents over in UTH Hospital. We held many in-person practice sessions as well, left behind a lot of our equipment so they can practice on their own, and actually most recently in February had a mini Top Gun of a sorts, which was really exciting. But of course this translates into registrars being able to assist during teaching cases between our faculty and theirs. And then of course, as important for capacity building are the friendships and partnerships that develop along the way. And I think that it's very important that not just within the operating room, but outside the borders of the operating room, that we develop these partnerships and relationships to enable and make sure that we are having sustainable partnerships. So in summary, institutions aspiring to engage in global health initiatives really need to make sure that they are fully equipped to support residents or medical students who are wanting to engage in global health initiatives. Having the funding, the collaborations, the allocated, dedicated time collectively shape a resident's experience, and lasting global contributions enriching their trajectory, leaving meaningful imprints on themselves and the communities that they serve. So I hope that this inspires you all to discover ways to create opportunities for your residents and your institutions so that they can learn and develop the skills that they need to leave lasting global health footprints. Thank you.
Thank you for that wonderful presentation. Our next speaker is Dr. Ikenna Okereke from the University of Michigan State, Thoracic Surgery Department, Detroit, Michigan. The topic of discussion is going to be creating a sustainable global surgery program.
Hi everyone, thanks all for having me. Yeah, it's really been humbling to hear and see some of the previous talks. It's really very impressive. So I'm really just going to give my personal journey and what started in 2010 to what is now, and how I decided to start my pathway in global surgery. So it was January 12, 2010. I'd been operating all day. I'm a thoracic surgeon, and I came home at 10 p.m. I turned on Anderson Cooper. I have an elliptical in my living room. I don't anymore, but at the time I went on the elliptical, I turned on the TV, and I saw the news. Massive earthquake in Haiti, 250,000 people feared dead. That number turned out to be up to about 300 to 316,000. We'll really never know, but roughly 5% of the population. I remember I stopped working out and I looked and I thought, you know, for some reason I need to be there, even though I had never done any mission work or had never traveled really outside of a couple islands. I never traveled to Haiti or the Dominican or the Hispaniola. So it took a lot of phone calls. I had to change my schedule. I had to talk to a friend who knew somebody who owed somebody who was an uncle, blah, 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 to get a charter flight from Fort Lauderdale into Port-au-Prince, stopping off in Turks and Caicos. And so I jumped up into that island, very beautiful. We were there to refuel. But 9 days after the massive earthquake, we were able to make it into Port-au-Prince. And I say that the statute of limitations has ended now, so I can say that I probably stole tens of thousands of dollars worth of equipment from from Indiana University, or was it at the time? I took it, it was old equipment, but I took it with me to get there, and this was the scene when I got there, that the airport had been destroyed, but the tarmac and the landing strips had been used as sort of a collection site for about 90 different UN delegations, and also millions of people who were displaced and had no homes, and the survivors. So when you actually traveled away from the airport, which was a challenge unto itself, into the city, this is what you saw. These are actually some pictures that I took. That it was, the main problem was that it happened at about 4 p.m., I believe, 5 p.m., and most of the buildings were, in essence, made of paper mache. They were very flimsy, and so many of the people who died because they were trapped on the inside. Many of the children who lived because they were outside still coming home from school or playing, and so there were a lot of new orphans literally at that time because a lot of the adults died in the buildings, and this is what it looked like. Even as I said, transportation was very difficult because most of the roads, many of the paths in Haiti have single lanes, like many, unfortunately, of low and middle income countries, and so it was very difficult. You had to sometimes take rubble off and travel on the grass to get around. And there were just a lot of people walking around outside, some with injuries, some with no place to stay. This is an example of one of the homes that I saw, which had been literally been cut in half. And then this was an example of one of the mass graves. And so I went in there 9 days after the bad event, already with a sense of guilt, knowing that had I made it a few days earlier, I probably could have saved some people who I saw lying around who had not made it because I wasn't able to provide the care at the time. This was our Airbnb at the time, which was, because I don't know much about earthquakes, but I didn't realize that there were these things called aftershocks, after tremors, which occur. And so we had to stay outside the entire time because the building which we were using for some of the goods was also very flimsy and had sustained some damage. And then this is the our transport that we had home. So I remember coming back and feeling this survivor's remorse or guilt or whatever you want to call it. And I thought at the time, without knowing all the statistics and some of the things that have been very nicely laid out here, I just thought, as a human being, this just seems inherently unfair. And what can I do to try to help this? And so it was about 10 months later that I went, and I happened to go right at the time of the cholera epidemic. I don't know if many people remember, but there may have been a UN delegation, I believe from Southeast Asia, but a UN delegation that perhaps may have been the source. And there were thousands or millions of people affected, thousands of people who died. And when we went back, we saw what persisted for years afterward, but these tent cities, and really the number of tents that I saw had actually increased, not decreased. So you could see that the situation was even worse, even months afterward, almost a year afterward. This was our initial operating room. And if you see there's a small little Bovie machine. The first time that we went, we had no Bovie machine. And so it was a lot of tie cut, or cut, or whatever. So it was a lot of ways that you just do damage control when you don't have the equipment. But I think someone very nicely laid out that my expectation was that I would go there and I would be doing fast lobectomies and esophageal, and you just go and you do what you can, and then you try to get smarter the next time. And so that was part of the evolution, which a couple people have said earlier. And then this was a 5-year-old who literally came to the area that we were using as a clinic and passed out. And she had cholera, and we were struggling to find an IV in her. We did. She ended up doing well after hydration and a few days in our area. So coming back that second time, I was even more distraught with guilt, feeling that, well, things hadn't gotten better, things had actually gotten worse. And so I thought, well, I'm just one person, but my goal as one person is to try to treat ill patients, create a safe, effective area to do surgery. But then most importantly, if I go 1 week a year, what happens the other 51 weeks? So what can we do to create a sustainable medical and surgical area? So next was trying to find the personnel. I think the last talk nicely laid out. She's at an institution where there are engaged faculty or people care about this. That's not universal in this country or other countries that have the means. So this was some of the staff. There's a pediatrician there, a family care physician, and then some actual Haitian doctors. And that was our initial staff of about 8 people in the yearly trips. We either went once a year or twice a year. And this is us just counting pills, because we would see patients as outpatients and treat diabetes, ringworm, other infectious disease control. Now, the yellow arrow is pointed at Mackinson. He's a local community resident, fantastic person, and he was someone that we engaged and we hired and we paid as our translator, because my fluency in French Creole is poor at best. I know cough and pain, and you need more. And so this is a way to engage the community and to create sustainable, because as I was learning from him French Creole, he was learning from me about how to recognize minor ulcer versus a major ulcer, how to recognize that someone does need preoperative care. And so in fact, Mackinson, in the end, became one of the people who was able to triage patients for upcoming visits. And so I think that that's a way, and that's been mentioned before, about how you engage a local community to create a sustainable pathway. This is Innocence, and he ended up being our scrub nurse / MA / post-op care nurse as well. And this was the upgraded operating room that we had. So next it came to the infrastructure. As I said, this was the upgraded operating room. This is a 3-year-old who had a chest wall sarcoma, where we had no ventilator at the time, so I found out that ketamine per se, propofol, works very well with the pulse ox, of course. And we were able to do fairly sophisticated surgeries in this. And as you see, we didn't have negative pressure ventilation. We didn't have, the other things that we take for granted in this operating. We did have a Bovie, but we didn't have some of the other things that we take for granted. But we were able to get the U.S. personnel that came with me, along with the local community. And I'll stress that the local community to help to be the ones who would get the suction tube in and who would get the drapes that we need, etc., while we were scrubbed. And then sometimes we had the traveling operating room. So this was a church, and the church had been destroyed, but the pews were still remaining, and so we used that as an operating room to perform procedures. I think it was a lipoma that was taken out. Once again, I thought that this was highly inadequate, and so based on that, in 2013, I started my own foundation, the Okereke Foundation. Remember, Tiger Woods had a foundation, so I get to have one too. So I named it after myself. And we decided to, with some of the Haitian doctors there, to build a facility. And the idea was that I would build a surgery center, and adjacent to it, we would build a medical center, a clinic, to see patients as outpatients, and then ultimately have some places where we could have them stay overnight and turn that into a full-service hospital with some radiology equipment as well, and ultrasound. And so we were going to start with the clinic and the surgery center. And so I became an architect and a construction person as well, in terms of trying to find out the best place to build it. We intentionally built it about 20 miles outside of Port-au-Prince because, as I said, travel, and it's much better now because there's been a lot of resources which have been placed in the highway system there. But we intentionally placed it because at the time we were sort of in the mountains. It's a mountainous area. And the mountains were very difficult for people who lived in that immediate area to get to the downtown. There were only 3 hospitals downtown, and they were always overflowed. You had to pay a certain amount of money, so we wanted to provide relatively as close to free as possible care. And so another thing that we made sure that we did, because we had some offers and some support from US contractors, but we made sure we got Haitian contractors. And so we had some US personnel who came down, and there was an architect and one construction person who came down to facilitate, but it was a Haitian construction people who were the ones that we primarily paid and that we had do the work to try to keep the money within the facility. This is when the outside of it was almost done, and then we had to deal with things, once again, I used to take for granted, like tiling, how to create a negative pressure ventilation, and then eventually, 5 years later, it took 5 years to build 2 ORs, but 5 years later, we were able to build the surgery center. And as I said, for the first year that we operated it, we had no ventilator, so it was that bag, that someone mentioned previously that we did. And then we finally were able to get a table, a sink, and in June 2018 was when we opened the Okereke Foundation Surgery Center. So sustainability, as I said, even back then in 2018, it was still me coming once or twice a year, and the other 50 years we didn't really have support. And so the next thing we wanted to do was to try to train the local people in that area, some of the Haitian doctors who really don't do surgery, train them to do some basic procedures, and then also try to either get US personnel to come down for a week at a time, X amount of people from my institution, or people from local areas. And so we were finally, after it took a couple of years, we were finally able to get, happened after the pandemic in fact, but we were able to get a surgeon from the Dominican Republic to come. And so now we have 6 months of the year we have coverage of surgery. That still leaves a gap, of course, but it's better than 50 weeks of the year with a gap. And then we also have surgery teams from the United States and from Canada who are able to come. But hopefully we can expand on that. And then as well, someone mentioned this earlier, try to teach the local community to perform some specific operations. Now we're not at the point of doing a laparoscopic or robotic surgery. I think if I try to buy a robot, my wife would divorce me. But hopefully eventually we can get to more sophisticated, but at least for now, circumcision is one of the most common procedures that we're asked to do. And so if we can teach some of the locals to use the GOM, I think it's called, I forget what it's called, but and do some of those procedures, that would be a major benefit to this area. And then what was one of the sad things I saw is that the first couple of times I came there, it was interesting that we saw a lot of disaster relief, and then we saw a lot of chronic illness relief. And one of the most common disease processes from which people were dying were inguinal hernias, because they had no one to treat them. I didn't know how to do an inguinal hernia, at least not very well, because it's been a long time since residency for me. I didn't feel comfortable doing it. And so you have people with giant inguinal hernias who are dying from that, from either incarceration or strangulation or what have you. And so if we can teach them or provide the whatever mesh or supplies that they need and teach them some of these basic procedures, have some of the general surgeons come down, you can save a lot of life. You can save a lot of life. You can improve quality of life just from things that we don't even think about, like circumcisions and inguinal hernia repair. And then future direction, as brought up by the what has been doing great at the University of Massachusetts. If you can get buy-in from your local department, then that is a great source of not only funding, but very enthusiastic residents who can push things to new levels and potentially affect things in ways that we haven't even thought about. And so that's our next step, is to try to make this a formal rotation, try to get attendings there for X amount of time that we can actually make it a ACGME approved or GME approved rotation, and then place staff there permanently eventually, like they've done so well in Tenwick. So it definitely has been quite the process. I think it's made me a better doctor. I definitely yell at my residents now for wasting anything. You can get three bites out of that rifle, not just 2. And I think that not only does it make you a better doctor, but then it is a good way for the trainees that you are training to see, there's more than just discharge. There's more than just op notes. That this is sort of the grand purpose. This is the main reason we really went into things, is to really impact people. And the bang for the buck, the amount of yield that you make in some of these areas is tremendous compared to what we can do here. So thank you once again.
This session is concluded. We'll begin the next one here shortly.
So I'll provide you. No, I'm kidding. So I do work with IU some in local spaces. I think trauma critical care for 25 years. Were you in Indianapolis at Methodist or IU Health?
We're just going to take a quick 2-minute break and get started shortly.
Like I say, it starts with a C. He does a lot of the towers and the heart transplants, and he's just, yeah, he's been there for maybe 5 or 6 years. He came just before the pandemic. He's great. They've had a little bit of turnover in certain but yeah, I did trauma for over 25 years. I was a doctor before that for 3 months, jumped back in and started doing general surgery, started COVID. So we weren't doing any of those surgeries, so we kind of kept the critical care about I started going out with the COVID coverage there in Houston. Yes, it's been an interesting adventure, but nice to meet you. Yeah, I won't talk about that.
I never felt one physically threatened, but they just, oh, you don't have the right credentials to operate. So last year when I sat in a hotel, the guards drank beer for 3 days, and then we did a day of surgery. It's not worth it anymore. I'm sad because I made a lot of friends there,
We're going to try to go ahead and get started here so we can catch up. We're about 30 minutes behind, so everyone that's going to be here, take your seat. We'll start in about 30 seconds. Thanks.
No, he just wants to look at it. Right? Okay. All right. Yeah. All right, so here's our. Yeah. You have your slides?
Siva, can you let him know? Siva.
I think he went to the back. I think everybody ran out because they were in so long this morning. Up here.
I live in Florida, so I'm like, yeah, I'm born in Cuba, so yeah.
We're so far behind. But there's one talk that is canceled.
Although I across the river in Camden, New Jersey. Lovely downtown campus.
All right, we do the podium, gentlemen.
All right, we're gonna get started right now, actually. This is the Artificial Intelligence and Innovation for Global Surgical Issues. I'm Peter Keneally from Colorado, and Delaney from the University of Chicago. First talk by Lee McCarthy, leveraging large language models and AI in surgery. All right, and realizing that we're 33 minutes behind, we're going to try to move along. Thanks.
Okay, great. Thanks so much for the invitation, the opportunity to speak. The best joke is at the beginning, and so you'll all get it when I get to the second part in the middle of the talk, and you just have to laugh extra hard so that you don't. I have a couple disclosures. The only thing I want to just mention is I do use some AI-assisted tools in the course of the presentation itself. So, every great artificial intelligence talk begins with discussing bundt cake pans. And for those of you who don't know what bundt cake pans are, I similarly didn't know what a bundt cake pan was, and this popped up on my Google search. And I'm sure many of you have had this experience before where you're doing something and all of a sudden you get these ads that seem really interesting because they go back to a conversation maybe you just had like the day before. And that's exactly what had been happening. One of my partners mentioned something about these pans, and we had a pretty long, very detailed discussion about bundt cake pans. And really the only explanation for why that advertisement came up on my Google feed was, this idea of passive listening. And this is probably a concept that, although many of these manufacturers refuse to admit is really something that's happening very often, if I kind of yell out, hey Siri, sometimes someone's phone, but there is this idea that there's passive listening happening, and what's really occurring through all of this is data is being collected. Real world information being gathered. And then the next question is, what actually happens with all this information? And I think that the vision behind the scenes is that there's this bot or AI tool that's kind of putting and processing all these things together. And maybe 3 or 4 years ago, this really seemed like a stretch imaginary thing. And increasingly, we're truly in the midst of a revolution around artificial intelligence. And this is a little bit more actualized. But I want to take a step back and just actually define AI, because the term itself right now is a catch-all, grab-all. It's used very commonly to describe anything in tech. And the definition first came out in the mid-1950s and really centered around the science and engineering of making machines intelligent. So really a robotic focus. But I'll highlight that John McCarthy, who described this, had kind of looked ahead and believed that there was going to be this idea of intelligent computer programs. And that, for the things that we're talking about, is really relevant now. You talk about science fiction and some of the things around artificial intelligence, and those are really what would be described as strong artificial intelligence. And these are things like artificial general intelligence or artificial superintelligence, where artificial intelligence systems either match or exceed the capability of human beings. And as far as we know, sometimes you'll see these like tweets or I guess they're X's now or whatever, but that this is not something that we've achieved before yet. Although it seems increasingly like we're getting closer and closer to at least some systems that can do this. But when we're talking about artificial intelligence and what it actually is, it's really weak AI is what we're focused on. And these are the fields and disciplines of machine learning and deep learning. And most of what we interact with in AI right now really falls into this kind of more broad stroke area of weak artificial intelligence. And it's part of our daily life already. You know, when you use Face ID, that's an AI computer vision tool that recognizes your image. You know, when you use Amazon Alexa, you know, voice recognition is powered by an AI-based tool, deep learning primarily. You know, when you dictate, Google Maps, Nest, you know, many of the products that we interact with on a day-to-day basis that actually, you know, probably most of us say make our lives better, have some form of AI embedded in them to allow them to execute. And you know, I think the reason that we're so open to using these and feel like it's okay, you know, that they're part of our life, is that the data is collected easily, that the analytics that are paired with it happen in real time, they're fast, it's seamless. You know, you're not doing anything extra to interact with these systems. And probably the most important aspect of how AI systems are designed for implementation, at least, is that it's not that they're telling you what to do, but instead there's teaming, the verb form, and augmentation of that human-AI interaction to make these things happen. So, you know, Amy Edmondson is a tremendous author and has written several books, one very recently, and the one prior to that was called Teaming, and actually described this idea that teams, you know, it's not a static thing, and instead, really teaming is a verb, and it's about teamwork on the fly. And, you know, if the trauma bay is a good example of this, everyone comes in with their role. You know, you kind of know what you're supposed to do in the trauma bay. Even if you've never worked together, you can make it happen. And to me, this is a really important idea of how to think about AI integration into the day-to-day, which is that AI systems are part of the team. And you know, maybe you've never interacted with that particular system before, similar to how you may not have interacted with that medical assistant, trauma nurse, or other you know, physician on the team, but that AI system is now part of the team, and it has a very described and clear function. And the second aspect of this is augmentation. This is like the fun cake pan parts. If you like missed the beginning, you know, this is like this. So it's not telling you like eat this bundt cake, those crazy side words on the right, but instead, you know, it's just like recommending. You know, maybe think about this bundt cake. You know, it might be pleasant to you. I tried to make the eyes not red, but that was not doable. So, you know, how can we actually use AI to team and augment, and then what can we do to actually realize this? And this is really, I think, critical for us as surgeons and clinicians. And this really came about in November of 22, and we'll kind of go back to the future here. AI was not used for that graphic. And that was ChatGPT, you know, an AI system that was built for conversation and allowed for individuals to actually feel as if they were talking to, you know, it's hard to anthropomorphize this, but really to talking to someone. Like AI was actually something that felt more realized. But I'll emphasize that similar to all the systems that we currently use, you know, ChatGPT is an AI system. And, you know, it's embedded with and powered by a commercial entity, OpenAI's very specific type of large language models, GPT 3.5 if you use the free version, or GPT-4 Turbo right now, which is if you use the paid version. And again, large language models. That's the underlying tech behind this AI system. How many of you have used ChatGPT? I don't know what it is. Yeah, it's actually very interesting, like to see that, you know, now I don't have to talk about the specifics anymore. It's become so much part of what people have seen in use. But I want to take it and actually describe, you know, how this works. So LLMs are just like any other model. I'm working on teaching my son algebra right now. He's 5. It's going moderately well. So it's really, you know, you're trying to solve for y, and you're just like a linear regression. There's a slope, an intercept, and you're trying to figure out, you know, what does that line look like. So kind of taken another way, you know, this is the interface for ChatGPT. You go to chat.openai.com, or if you use Claude or Gemini, the Google form, or whatever LLM system that you want to use, you get a system like this, and there's a place to interact with the tool. And what ChatGPT is doing is really just solving for why. And so, with this prompt, like me, surgical oncologist, giving a talk, and that's the prompt, that's the X of the equation. The M and the B come from slope and intercept, the training piece of the data up in front of it, and then the output is Y, and this is what ChatGPT would output from that prompt that I gave it to describe it. But again, it's math. It's taking words, embedding them into a feature space that's numeric, and then it's predicting what should be the next token or word. Everyone, like through that show of hands, seems like has interacted with or knows about ChatGPT, but there's a lot of large language models out there, and these date back to 2019. GPT-3, OpenAI's first model, was released at the end of 2019, but probably didn't hit anyone's radar because it kind of functioned at the 8th grade type level. But even now, there's tons of other models. But the reason that the ChatGPT, Bard, Anthropic's model, Claude, all kind of have reached people's interest is that they're embedded in systems. You can interact with them in a way that allows you to actually use the tools. And this gets to, how is AI implemented and integrated into the things that we do? And it's really around the system. I think I've said system like 100 times and stuff, but that's what it's about. It's not just the model itself, and it's not AI in and of itself. It's agentic AI systems, allowing a system to pursue a goal guided by a human with either direct or indirect supervision. Training resident. So I'm just going to describe two surgical agentic AI opportunities. One is work that's done, we'll talk about kind of more broadly, and one is something that we're doing in our lab right now. So efficiency agents, things that help make things more efficient, and then clinical agents, things that are integrated into the day-to-day. So efficiency agents. We all, this kind of summarizes how people feel about clinical documentation, frustrating, challenging, and takes up a lot of time, and really kind of detracts away from that patient, clinician, human interaction. So perhaps there's an opportunity to introduce AI into that interactivity to help actually ease the burden of clinical documentation. So there's been a development around ambient scribes in the office, and really the idea here, the framework is to go from physician-patient conversation, capturing that audio, taking that audio stream, diarizing it, turning it into something that can be used, turning it into a transcript, extracting that information, and then summarizing it into a medical note. Lots of different steps. And I argue that we've done pretty well at capturing audio, though when I try to capture audio in my car, like I did talk with my car, that's terrible. But for the most part, pretty good at capturing audio through the devices we already have. And actually speech recognition, on the way there. Where we've really struggled to date is the information extraction and summarization. That piece where you take the information from the transcripts and actually turn them into the medical note. LLMs have enabled this. So the most updated frontier models have really allowed that summarization, extraction, and turning into a note to actually be real. And so now, Microsoft, Amazon, each have products around ambient AI tools to help with clinical documentation. And these are now being implemented. So this is a study from earlier this year in the Kaiser system. And over a period of just about 2 months, they allowed clinicians to use this tool, which basically did ambient listening. It took that conversation and provided a summarized note, which then the clinician could use or not use. And while it didn't necessarily reduce the time in an appointment or in-basket activities or orders, what it did do is decrease, this graph is a kind of strange way of showing this, but that upward inflection on the graph was decreased time with documentation. So an improvement through this LLM-based AI system. All right, example number 2, clinical agents. So everyone knows the operating room is a limited resource, and efficiently utilizing it has lots of downstream impacts. And to me, a really critical aspect of doing this effectively is actually like estimating how long the case will take. This is not a problem that is unfamiliar to many of you, but OR case length predictions are terrible. And if you underpredict how long a case is going to take and a case takes longer, you now have extra staff overtime. If you overpredict the case, you have the opposite problem. You underutilize the resource. If you can do a better job at this, really substantial opportunity for improvement. And at our own institution, we looked at how accurate the case length predictions were, and less than 50% of the cases were accurately predicted. We define accurate prediction within 20% of how long that case is going to take. And so, our thought was, could we use large language models directly to predict how long an OR case would take? And this is really leveraging unstructured data and an LLM only. And so, literally what we did was we took the notes for that patient prior to surgery, we put them into the large language model, we asked the large language model to predict how long that case was going to take just using those notes alone, and then we use that output as the case length prediction. And that alone, just that very simple task, LLM has the capability embedded in its training to actually predict at the same level as the EPIC case length estimate. So we did it a couple different ways that you can modify the LLM's output, but essentially EPIC's error was 60 minutes and the LLM's error was 60 minutes. And if you look at the accurate case length prediction, very, very similar. And so what's happening under the hood is that you're taking this note, this prompt, tell me how long this case is going to take, and then the LLM is predicting the next token, what should come next, and so it's giving you various outputs and then the probabilities around them, and then we have the ability to modify those based on things like the temperature of the output to help ensure that it's reproducible, what's the highest probability, and what makes sense for the use case. And so this is a system, from end to end. Physician enters note, note used for LLM, LLM makes the prediction, and that's it. I mean, it sounds super easy, but it's really leveraging this AI tool to build a system. So often people ask, there has to be a better way to do these things. I think the answer is agentic AI. And I'll just leave with kind of 4 ways that I really think about this. That large language models aren't new, but we have the ability now to leverage them differently. And again, they're just predicting the next token. We should integrate LLMs into AI human systems to work together. I provide a very rosy picture of AI. I think that others are going to provide some balance to that, which is good, but caution important. We just have to know how they work. I think as surgeons in any environment, recognizing how these tools generally function is really critical. So I really appreciate the opportunity to talk about this. It takes a huge team to make these things happen, but thanks again for the invitation.
That was great. Thank you very much. Unfortunately, we don't have time for questions, but you did a great job. Again, remember for the speakers, this is a 15-minute talk.